Let me break the patient populations down into two distinct categories. The first is the completely asymptomatic patient. Some of these people are at high risk for underlying coronary disease and deserve to have some type of cardiac imaging procedure. Some examples of this would be people at high Framingham risk for cardiac events over the next 10 to 20 years, patients with a high coronary artery calcium score, patients with new onset atrial fibrillation, those who are more than 2 years after some type of coronary intervention, such as coronary artery stenting. All of these people, although asymptomatic, could be good candidates for referral. We don't just think of chest pain as a tip-off that coronary disease may be present. We think today about anginal equivalents. Our definition of anginal equivalent has to do with various types of chest or shoulder or back discomfort, particularly if associated with exertion, exertional dyspnea, changes in the electrocardiogram. These are all anginal equivalents that could be telltale signs of significant underlying coronary disease. Patients with arrhythmia, syncope or near syncope, or who have already had an intermediate risk Duke treadmill score on a regular treadmill test, or other patients who deserve one or another type of cardiac imaging procedure. The right test at the right time for the right patient is sort of a mantra that we have adopted. It reduces costs, can reduce a person's risk, and obviously can save time, reduce time away from work and other more enjoyable activities, and reduce patient anxiety. Cardiovascular imaging is one of the more dynamic, rapidly changing fields. We have the very latest cutting-edge SPECT equipment, PET imaging, advanced echocardiography equipment, and the latest CT and MR equipment. We have developed a very concerted effort to reduce radiation exposure to a level as low as reasonably possible. Stress echo will usually imply injection of a contrast agent. Stress-only SPECT will imply a very tiny amount of radiation, less than 1 millisievert of exposure. CT angiography requires contrast and X-ray exposure and is probably less desirable in younger people and in women. More complicated patients will be better served by PET myocardial perfusion imaging or by cardiac MR. Patients who are unable to exercise and require pharmacologic stress, myocardial perfusion PET imaging is the test of choice. We recognize the importance of getting the results of imaging tests back to our referring physicians as quickly as possible. My name is Dr. Timothy Bateman. I am co-director of cardiovascular radiologic imaging at St. Luke's Mid-America Heart Institute and professor of medicine at University of Missouri, Kansas City School of Medicine.